Good afternoon, everybody, and welcome to the webinar. Thank you for joining us. We've got 466 people registered today, so it's an interesting topic and nice to have so many people attending. The webinar will last an hour. If you want to ask a question, we're going to take questions. The three of us will take questions together at the end, so if you put them in the Q&A box, and your certificates will be emailed after the event. There are three speakers today. I'm one of the speakers. I'm going to speak at the end. So our first speaker is Dr. Raka, and she actually organised this. She's put this together, and it's her that's been the driving force behind it. Raka trained as a psychiatrist in India and was awarded the Florence Nichols Prize for the Best Outgoing Trainee. She then pursued neuroscience and was awarded the first prize in her cohort. She held a Marie Curie Fellowship in Neuroimaging and earned a doctorate degree in Germany. She then came to the UK, and she's currently training in child and adolescent psychiatry in the Tavistock scheme in London. She's a carer herself and has had many career breaks. During the ups and downs of her career in the UK, it's one of the neuroimaging groups in psychosis at the Institute who supported her career trajectory. She was nominated for the RC Psych 25 Women in Psychiatry last year, and she actively contributes to the college, focusing mainly on caring responsibilities. So thank you, Raka, and over to you.
Thank you so much, Wendy, for that very heartfelt introduction. I will start sharing my screen. So I'll be speaking today on physician carers in the UK, a hidden workforce. And I say hidden because there are lots of initiatives that are there. However, there are things which are left to be addressed. Now, carrying on the introduction that Wendy has just given me, I want to say that I arrived in the UK 10 years ago as a regular IMG, and I arrived in the UK 8 years ago as a parent carer. And this is a picture of my 6-month-old son in an air ambulance. And we traveled to the UK with 2 pilots, 2 healthcare professionals, 1 parent. And you can see the little cubicle in which he was supposed to be. And even at 6 months, he refused to be in that confinement. And that has been our motto: not to be confined and not to be limited by all our circumstances. So why is this important to talk about physician carers? And I'm using the word physician because we are an international panel today, and to make it sound relatable across the countries. So 5 million in the UK are unpaid carers. This is a report done by Carers UK in 2019, and which means that 1 in 7 juggle work and care. About 20% gave up work more than 10 years ago. So why is this important in the context of NHS? It's because there are 250,000 carers working in the NHS. Some of them are doctors and some of them are psychiatrists, and we don't know the data. I did an informal survey among some of the women doctor carers that I came to know. And it was a small group, about 45. And what I found that 66% continue to work and juggle the caring responsibilities and work responsibilities. 16% of them, the partner had to give up work to support the possibility of carrying on work. Among those who didn't work, 52%, and this is in 2019, so pre-COVID, didn't have options of working remotely, and hence there was no way they could leave their caring responsibilities and work. COVID, of course, has changed that to an extent where we are able to juggle that more efficiently. 38% didn't work because of child's needs were great enough not to be able to do any kind of work. So why is this what important from the perspective of trainees and then consultants and SAS doctors? So first I'm going to present why is this important for trainees. Health Education England doesn't recognise carers. Now that seems like a very bold, huge statement. Health Education England currently is looking at the needs of carers, but their focus is, again, mainly on carers of patients. And it needs to be the focus on the staff is not that clear. Recruitment and training restricts achievement to 5 years. Some of us have huge career breaks where, ignoring everything we've done prior to 5 years probably is not fair. Training doesn't take into account achievements and competencies prior to training. Training presumes a crisis-free trajectory. The advice of out-of-program career break puts a financial strain on these families. Remote working competencies are unclear. So remote working, of course, has been facilitated, but it's unclear as to how the ARCP panels look at the competencies. Coming to the consultants and SAS doctors, we find that, So firstly, trusts don't have non-executive director for carers in most trusts. There is one, and I will mention about that later. NHS trusts allow 3 to 7 days of paid carer leave only, sometimes up to 10. This is not specific to NHS trust. This is across England, like Carers UK had shown. However, annual leave is an entitlement. Sick leave is an entitlement if you're sick, but carers leave isn't an entitlement, and you have to negotiate for every single of those 3 to 7 days. And some people have much longer admissions where that would not cover anything. Flexible working is still an issue. COVID has, of course, facilitated this, but it is still an issue. Locums is not necessarily an option. So even if you're, as a consultant or SAS, it is not that if you start doing locum, it'll give you the necessary flexibility needed to cater to your caring responsibilities. Contracts, again, presume crisis-free employer experience. Now, at this point, I want to highlight a few things. One is, so Health Education England, for example, recognizes primary carer. In the UK, only one person can be primary carer, irrespective of the child needs. That is an issue. Secondly, the other thing is that one can recognize carers if they are taking care of adults, but the moment it comes to child, we fall within a legislative gap between the Care Act and the Children's Act. And parent carers are often not recognized. All of this delays progression and increases gender pay gap, because most of the time the caring responsibilities do fall on the women. Now, we are a strength because we've seen both sides of the table. We constantly deal with uncertainties at work and life, and so don't need resilience training. And what is NHS losing out by not focusing enough and not retaining perhaps this workforce? So here I'm going to present data shared very kindly by Fatima Khan Shah, who belongs to the West Yorkshire Partnership Trust, and they have recently won a lot of awards from HSJ for their work on carers. Now, they did a business case study before they started the work in their ICT, and they found that 1 in 5 among the healthcare workers in their trust and the ICT are juggling work and caring responsibilities. 80% hadn't talked about caring roles. 50% were considering leaving their role for caring responsibilities. And they made a case that actually, if they were supported, trust could save £4.3 billion. Carer's passport is something that NHS employers do endorse. However, it is not really implemented across all trusts as yet. And also, it doesn't really solve all problems regarding out-of-hours work, which is an essential part of many of the doctors' jobs, not so much for other healthcare professionals, apart from nurses and social care workers. So some positives, it is not all doom and gloom. So last year was quite crucial because so UN resolution have now clearly said that they will promote and protect rights of those with rare disease and their families. Of course, it doesn't cover all conditions for which you might have caring responsibilities, but it is a good, important start. The very exciting thing for doctors is that GMC strategy last year clearly states that it recognizes doctors and caring responsibilities and supports flexible working. NHS England has been trying to focus on this, and they have a commitment to carers guidance released in 2014. However, the commitment to carers is focused on the carers of patients and not so much on staff. They have advertised for a clinical fellow last year, and hopefully there will be some focus on the staff carers as well. Among the deaneries, London Deanery has been quite proactive. London School of Psychiatry has appointed a wellbeing TPD last year, and in ST6, working in London in psychiatry, has started a carers group as part of the wellbeing project. Women in Mental Health Special Interest Group last year ran a 25 women project to show that there can be different trajectories and challenges, and you can still come out shining. Now, what's important is 4 out of the 25 had significant caring responsibilities. So this is quite significant. And I would really encourage you to listen to the Women in Mind event that was done last year, where Baroness Hollins, who is one of our past presidents of the college, talks about her journey and her caring responsibilities, and yet becoming president of the college, which is very moving. And it also has inputs from the CEO of Carers UK and the Institute of Psychiatry, who has the first ever Carers Champion, to talk about some of these complex issues. There is a Women in Medicine Carers network that we have formed to kind of focus on work-related issues, because any changes that is going to happen NHS-wide or health education England-wide is not going to be restricted to just psychiatry. So, although there are lots of these very good and helpful initiatives, they're still in their infancy and things are not really in place as yet, and therefore the onus really lies on the carer to access help. First thing and most important thing, of course, is to recognize yourself as a carer. And then there are various different things that one probably needs to focus on to have a fulfilling life. Now, for career, you could go to psychiatric support service, the practitioner health program, occupational health, BMA, to discuss work arrangements. This is important because under the Equality Act, of course, it is a problem that carers is not one of the 9 protected characteristics, and currently there is a movement to help recognize it as the 10th protected characteristics. But till that time it happens, the Equality Act does give you protection against discrimination by association, and hence there are stuff that BMA and occupational health can help with that. Now, you may or may not be a trainee returning on supported return to training scheme, but even then, nobody stops you from having a chat with supported return to training champion, freedom to speak up guardian, or guardian of safe working, just to have a think about how things could be facilitated differently. It's important to look after your growth, and for trainees, professional support units are great. They provide really excellent coaching. Others can approach BMA Wellbeing for coaching. Many families face pretty hard financial challenges. There are RMBF and other charities. Now, we are providing you a list of resources, and you will be able to find information about other charities. Then on top of that, there is Citizens Advice, and contact a family who can give that advice. And finally, look after yourself and stand tall. There is no shame in asking for help, no shame to catering to your needs. Finally, this is a poem that I have shared with some of my other women doctor carers, and it resonates with them, and I hope it resonates with you too. To our colleagues and our patients, We can stay awake on on-calls, stay awake when our loved ones are frail. We can stand strong when it comes to you, for we've been there in the dark and known fear. You don't need to tell us life isn't a straight, sweet road. We didn't wear those rose glasses when it came to anger and despair. We've carried on for decades. We work, we stop, we start again and again. We hope you will care to walk with us yet again. And finally, lots of people to thank, because on this complex journey, it is not something you can do by yourself. And most of all, I would like to thank Paul Rees, who is the CEO of the college, because he's the one who actually encouraged and allowed this webinar to happen. So very grateful to him. Thank you all for listening. And it now follows to our next brilliant speakers, and I hope you'll have a really useful afternoon. Thank you.
Thank you, Raka. You covered a huge amount in very little time, so thank you. I'm now going to introduce our second speaker, and it's one of the wonders of having a virtual meeting like this, that she's joining us from California. She's Professor Christina Mangurin. She's a professor and vice chair for diversity and health equality in the UCF Department of Psychiatry and Behavioral Science in California. She actively works to further the advancement of women and minorities within medicine. She's done projects on wellbeing, childbearing, family leave, and equity. She has over 100 publications, and her work has been widely published in this area, including in the Harvard Business Review, the New England Journal of Medicine, the BMJ, JAMA, and the American Journal of Psychiatry. She's received numerous awards for her work, including her university's Chancellor's Award for the Advancement of Women. So, Christina, thank you very much for joining us, and over to you.
Thank you so much for that kind introduction, Dr. Byrne. Let me share my screen here. Okay. Right, and I think you should be able to see it now. Excellent. All right. Great. Okay. So I'm going to be talking today about promoting equity for caregivers in medicine. I'm really delighted to be here and to be shining a light on this subject that isn't discussed much. And you learned so much just now from Raka about her experience in her advocacy in this area. Some just minor issues. I use the term informal caregiver. It's synonymous with carers, which I'm learning is more common in the UK. And much of what I'll discuss is with caregivers being women. In the US and in the UK, as I think Dr. Burns will show some in her slides, the majority of caregiving is done by women. I understand that some of you out there are men and some of you are caregivers yourself. I don't want to discount that in the slightest. I'm very glad that's happening, but I'm just going to be speaking more about caregivers who are women today. I also want to make a caveat. We know gender isn't binary, but the data we have is binary. So we don't really know very much about people with other gender identities, and we don't have as much data on women of color as I would like. But that said, in the cities that do exist, women of color have experienced more challenges in their workforce. Here are some of the just funding disclosures that I have. None are related to this work. Oh, for some reason it's not advancing my slide. Let me see. I'm going to stop. I apologize. I'm going to stop my screen. There. Okay. Let's see if I can do it again. I apologize. Okay. There. Let's try to share here. Okay. Well, you can see now. In a minute. Great. Okay. All right. So here's my funding. As I was mentioning before, none of us is related to the work that I'm going to be discussing today, specifically other than the Doris Duke Charitable Foundation, and just recognizing that I stand on the shoulders of a lot of different women who've inspired me over the years. The objectives that I'm going to have today is I'm really going to be talking about my journey in building research in this area. And it's related to my personal experience. So I'll be talking about the research that I've done of caregivers in the medical setting, physician mother caregivers, and then some policy studies that I've done. So the first thing that I want to mention is I want to mention that I'm here today because I'm a caregiver myself. This is my son, Anderson. Anderson was born with a rare genetic disorder called Wiskott-Aldrich syndrome, and he needed to have a bone marrow transplant when he was 10 months old. That was in August of 2012. I'm a carrier of that genetic defect. Here he is celebrating his anniversary of his bone marrow transplant with a blizzard, which is a very American treat. And I share this experience because my research and my whole life really changed a lot because of that journey of being a caregiver for Anderson in many, many ways that I'll describe here today. So first with the caregiver for patients. So, when I was taking care of Anderson, I was already a psychiatrist, I was an administrator, and I was a researcher. When I was in the hospital with him for 2.5 months, we were living on an inpatient unit, I saw all of the systemic failures and missed opportunities to take care of and support parents like me when their children were sick. We all know as psychiatrists that if mom's not okay, baby's not okay. And there just weren't systems in place to take care of the parents. So it was at that time, shortly thereafter, that I wrote a piece in BMJ with Dr. Cowie, who was my bone marrow transplant doctor, the doctor for my son. He's a wonderful head of the bone marrow transplant, pediatric bone marrow transplant unit, about there's a missing vital sign. Nobody's checking in on the parents. I then wrote a case report about how we could do so much more to support the caregivers. And this was really based on my experience. And some of my suggestions were really about, why don't we have a psychiatrist that can come to the bedside of the parents? They won't allow it, at least in the United States, because the mother isn't the designated patient. But there are some innovations such as the Memorial Sloan Kettering, where they give a mother a medical record number, and then the consulting psychiatrist can come by and treat her. Because as we know, postpartum depression can adversely affect the outcomes of regular, even healthy kids, and much less kids who are struggling a lot with medical illnesses. I then collaborated on very many studies with other people in pediatric bone marrow transplant, trying to characterize the needs that parents with other children who had immunodeficiency disorders needed. And really, frankly, most of them just needed to be asked, how are they doing? And connected to support groups. It was sad. One of the quotes from one of the qualitative studies I had actually said, it would be great if the doctor asked me how I was doing once a week. Let that sink in. They're stuck on an inpatient unit with their critically ill child, and all they want is their doctor to ask how they are once a week. I think a lot of times people are just afraid they're going to open up a can of worms if they ask somebody how they're doing. But sometimes that's really all that somebody needs. Also, there was a real dearth of just connecting people to support groups. I personally found a Facebook group for Wiskott-Aldrich syndrome carriers and families to be extremely helpful for me, having a child with a rare disease. And it should just be part of standard operating procedures to connect families to these kinds of supports. I then found partnerships with folks in the neonatal intensive care units here at UCSF, and found, I was trying to see, are we even trying to see whether parents are sick and whether they have postpartum depression? Because some of the studies that I had done before had shown that, a lot of these parents are really, really struggling on these inpatient units, with over 50% of the parents with acute stress disorders or postpartum depression. And the same is true in the NICU. Despite the evidence of high prevalence of postpartum depression among parents in general, and then on the NICU, At least in the US, we are not doing a good job at screening for depression or anxiety or treating. And in my opinion, that treatment should happen at the bedside so a mother doesn't have to leave her child, or treating the parents in that setting. So I talked to you about how I started, where I was starting really focused on these patients, my experience, what could we do in that setting for those kind of parents? And then I got wondering, began wondering about the experience that maybe there were other people more like me, other physicians that were more like me, and how many of them were caregivers. And so I'm a part of a research group, part of the Physician Mothers Group, which is a Facebook community of, I think, 70,000 women, physician mothers. And it is international, though it was started in the States. And we had done a research study in this group. And I wanted to quantify this. And so we did a study and found that, of these mothers, 16% are also informal caregivers, 1 in 6, right? And problematically, a lot of these women have significantly high rates of mood and anxiety disorders and burnout when compared to physician mothers in general. And as Raka was mentioning, few policies allow family leave across a women's lifespan for these informal caregiving needs. I've also replicated this study in a way at the University of California, San Francisco, and very similarly, about 16% of the women who are moms are informal caregivers. And many people are like me, they're mid-career, actually in a sandwich era. So I kind of graduated from my son who's now is recovered and cured of his disease, to now I'm caring for my elderly father who has, some mild cognitive impairment that's becoming not so mild. And that's just a reality for many women in medicine. I will say one of the things I'm really proud about is this program that was led by an organization in the United States called the Doris Duke Charitable Foundation. And the leaders of that group had a great idea to create a fund to retain clinical researchers and scientists. And they were really interested in supporting carers. And when we read it at UCSF, we proposed one that was actually to support people who were informal caregivers caring for ill relatives. And we were one of the 10 sites that received that award. And multiple publications have come out describing positive outcomes. Here at UCSF, we've given these, pretty small $30,000 grants, but had a $7 million return on investment over the 5 years that we ran the program. And something that's unique about the program that we run at UCSF is I run it with Dr. Christina, and she and I are both psychiatrists. So from the beginning, we always wrapped in some sort of level of group support as well as resources to make sure that if people needed it, they had access to psychotherapy for themselves and their families. Now, we kind of have been mentioning a little about COVID, and as everybody knows, COVID is the great revealer, right, of a lot of the inequities across the globe. And it's very clear, and I don't think I'm surprising many of you, but there have been multiple systematic reviews that have been done to look at who's most vulnerable for psychological sequelae during pandemics. Well, not surprisingly, it's women and caregivers specifically, frontline workers, people of lower socioeconomic status, younger populations, social isolation. All of those things put people at risk. And then if you start combining any of these, the risk becomes higher. This is just showing how many publications across the globe, this is on Lit COVID, have been published on psychological impact of COVID since the beginning of the pandemic. It's thousands of articles. So we did a follow-up study, the Physician Mothers Group did actually in the middle of April of 2020. We sent a survey out to the Physician Mothers Group. It was a mixed method study. We received almost 2,000 responses. And over 40% of the physician mothers had symptoms consistent with anxiety. sometimes very severe anxiety. And 19, this is compared to, as many of you know, 19% of the general population. The most at risk were frontline workers, not surprising, but also informal caregivers. I honestly can't imagine what it would have been like dealing with all the issues we had with Anderson during COVID. It just would be really impossible. Something that's very concerning is among those, this was through a GAD-7 scoring, 41% of those who had anxiety were moderate or severe, and almost 20% were very severe. And so now I'm going to shift gears a little bit because it was something that Raka had mentioned in her study was about some of the policies. And I learned from a really incredible lawyer and colleague of mine at the University of California, Hastings, Joan Williams, to really focus on policies, because policies are things that we can put in place and have a lasting effect. And so it sounds dry, but I love policies, and I think they can help overcome structural inequities. So one of the things that I did was I worked with a lot of, this is less policies, but it's showing the benefits of some policies. So in the United States, as many of you know, we do not have great standardized, nationwide paid family leave policies. So rely on our employer for these paid leave. And we decided, that we were going to write, many of us from the American Psychiatric Association. At that time, I was the chair of the Council for Minority Mental Health and Health Disparities. And we did a review of the literature to see, well, how did paid family leave impact the mental health of women, and did it help? And, long story short, if you have paid family leave, there's decreased postpartum depression, there's decreased intimate partner violence, there's improved attachment, there's, decreased medical aspects in terms of your child's health and breastfeeding initiation. There was so much evidence of this. It was very clear. So I feel very proud of this piece. And knowing this, and knowing that the American Academy of Pediatrics had recommended at least 12 weeks paid leave, which I know is still not enough, but that's what that's the standard that we would go towards here. Is necessary. I decided to look at the top schools of medicine across the country and examine what their leave policies were. And I did 3 different studies that I'm going to present here and just kind of show what a difference it makes based on privilege. So if you're a faculty member, 100% of the schools had a policy, and that policy had a mean length of 8 weeks, but the range was 2 up to, there was one place that had up to 24, but that was a real outlier. If you were a trainee or a resident, only 50% of the institutions had a policy, and their leave was much lower at 5.6 weeks. If you were a staff, only 2 out of, it was much lower, 17% of the sites had a policy, and it was 6 weeks, but again, for only these 2 sites. This is just inexcusable in my mind. And so what I did is, a colleague of mine, Kirsten Bibbins Domingo, who's the Vice Dean for Health Equity and Population Health at UCSF, has told me, scientists create the stones for policymakers to throw, right? And so that I'd created some stones, and this helped things to change. So UCSF actually moved to 12 weeks of family leave. So did many other institutions. The American College of Graduate Medical Education and the American Board of Medical Specialties both approved, and this is a big leap for us in America, 6 weeks of leave for trainees. And I wrote about caregivers being an essential member of the workforce in the New England Journal with an amazing colleague of mine, Megan Halley, who also has a son with a rare disease. And my next target, speaking about what Raka was saying, is really trying to find a way to have a paid leave for informal caregiving. So whether that's extending family leave later throughout the lifespan, and that's how it would be paid for, so that at any point you could take those, let's say 12 weeks that you get, not just for childbearing, but for any other kind of family leave issue that you might have. And I just think it's the right thing to do. And I think it's going to help retain our workforce. So then I was asked also to include some resources for folks, and I can put one of the links in the website into the chat after I'm done. But during the pandemic, I led some of the well-being efforts at the university, and one of my colleagues, Alyssa Appel, who's brilliant and one of our vice chairs for adult psychology, had the brilliant idea to create this really robust website. So I'll share some of the URLs. I'm a little technically challenged to be able to share at the same time as I'm speaking, but I'll share it in a second with you. This website has tons of information, a wide array of written content, curated free mental health apps, resources for caring for children, webinars, and then there are these self-help videos. And there's actually this one that I did is balancing act being a mom and a healthcare provider during stressful times. And I think for many of you who are carers, you may relate to this. I'd also like to mention that Dr. Appel and I have been doing a lot of work in the importance of groups and peers. And so I've started different women's groups at the university and different professional organizations. And we started some that were mom groups within UCSF. And I think that those groups are both not only a support for each other. I do it, as I mentioned, that Doris Duke Charitable Foundation grant that we have a group of other informal caregivers at the university. They can support each other through what's difficult. And make each other feel heard. And, hearing about an ICU doctor who has 2 kids who are unvaccinated under 5 and not being able to get her kids back into daycare, and what she's going through is just heartbreaking. But she had people who heard and understood, and then we can advocate for things at the university level. So I feel like those groups end up being very, very powerful and really important for well-being. Oh, and then this is just some data that are, the website has been viewed, and lots of views of our webinars. So I'll just, my conclusion is that, informal caregivers, as I mentioned, do experience a lot of psychological distress. And unfortunately, our medical establishment is poor at addressing distress among our patient caregivers and our staff. Policies really should be in place to screen caregivers and our patients for depression and anxiety, and policies should be in place for more flexible leave. And these are just some pictures of some of the women groups that I was mentioning, and women that I deeply admire and that give me joy in my work and life. Thank you.
Thank you, Christina, and thanks for all the huge amount of work that you've done on this. You've summarised it very quickly, but there's a huge volume of work there. So thank you. So I'm just going to speak for about 10 minutes now, and then we can have some questions at the end. So hopefully that has shared my screen, and you can see my slides. And then mine don't want to move either. Have now. So I'm going to briefly tell you a little bit about me, some of my experiences of supporting doctors who are carers, some case studies, details slightly altered, talk about the price of caring, some recent reports that we've had on wellbeing in doctors and how that links to carers, talk about some sources of support, and some recommendations for what we might do in the future. So about me, I became a consultant old age psychiatrist in 1990 in Leeds. immediately became involved in postgraduate training, first as college tutor, and then occupied various roles, including a management role at one point. I became head of the Yorkshire School of Psychiatry. After that, I was dean of the college from 2011 to 2016, and I was president from 2017 to 2020. I now work 2 days a week clinically as a community consultant in old age psychiatry in Leeds, and I do 2 days a week as a National Mental Health Advisor for Health Education England. My caring responsibilities, as Christina mentioned, I was a member of the sandwich generation. At one point, I was caring for children and for elderly parents. I was the first woman consultant in my hospital, and I was the first to take maternity leave. 2 children, both grown up now. That's my son Jeremy. When he was little, they've both grown up and left home. My parents lived into their 90s. My father had quite severe dementia, and they needed support. But my caring, compared to the previous 2 speakers, my caring has been a lot easier, but still hard. When I started managing trainees in the 1990s, there were very few options for support. It was still a very sort of macho kind of environment, and people were just expected to get on with things. There wasn't a lot of a recognition of people's need for support. Less than full-time training was available. It was called part-time training, then it was called flexible training, but there was a very limited number of trainees that could have this. There was a fixed budget, and if you wanted to train less than full-time, you had to wait for someone else to finish before you could get a place, and a very difficult application process that took a long time. And there was resentment from consultant supervisors and full-time colleagues. So I'm not saying that that's gone completely. I think some people still experience that, but it was worse then. And I know when I was running the training scheme, if I rang up a consultant and said your next trainee will be less than full-time, they would get really quite annoyed about it. So things have improved. Less than full-time training is now more available. These are sort of category 1 people who can get it. If you have a disability, if you have ill health, if you're responsible for caring for children, and that's men and women. I can remember the huge shock the first time a man asked to work less than full-time so he could look after his children, but that's more accepted now. We have men doing that. Or if you're a primary carer for an ill or disabled partner, relative or other dependent. So that has improved. Things I learned, really simple things. And when I was writing this, I thought this is a bit silly, but then those of you who know me will know I spend a lot of time on Twitter. And today I saw somebody on Twitter who was saying, well, how can I sort out my childcare? I'm starting a new job in a week and I haven't had my rota yet. We always allowed rota requests. So we always wrote out to doctors quite a long time in advance of them starting and let them make requests, release the rotas early so that people had plenty of time. Considered caring responsibilities when allocating placements within rotations. You have to be careful with that, because the people who don't have caring responsibilities have a right to, so you have to balance things carefully, but you need to at least think about it. Consider flexibility with hours. At times I had people who would maybe work 10 a.m. till 6 p.m. rather than 9 to 5 or 8 till 4. And as long as they could find somebody to be around to just cover that gap if there was a real emergency, that was okay. And understand employer rules on carers' leave. There are set rules within the NHS, but employers do seem to vary a bit on how they interpret those. So case study 1, this is sort of loosely based on a couple of trainees. Trainee flagged up as having many short periods of sick leave. And those of you who work in the NHS will possibly even seen it as a bit punitive if you have a lot of periods of sick leave. Well, it used to be more than 3. I don't know what the numbers are now. Then you get an interview to see what's going on. It can be punitive, but can also be really interesting and helpful to find out why this is happening. And with this particular trainee, she was supporting her mother who had schizophrenia. And what was actually needed was more care for her mother so that she wasn't doing it all and she could get on with her work. Case study 2, a trainee resigned without explanation. And we discovered they'd been placed in a job where the commute would take over an hour, although not geographically very far. So that was when I was managing the Leeds scheme, and it's not huge geographically, but because the traffic was so bad at the times that the trainee would need to travel to fit in with childcare, they just couldn't make it work, and they just decided to give it up. So we managed to arrange a swap with another trainee who was happy with this. Again, I wouldn't, just want to tell another trainee they'd got to do the difficult journey, but they lived in a different place, and it was easier for them. And case study 3, I was really proud of this. This is 2 trainees who were married to each other, and they had a baby, and they asked a job share with each of them working alternate 6-month placements, as the training slots were 6 months each. It had never been done before, therefore everyone assumed it couldn't be done because it had never been done before, but actually it was done, and we made it work, and they both successfully completed training. So that was good. A bit about the price of caring. Training a doctor in the UK costs over £500,000. That includes the money that the doctor themselves pays to get trained. And we know that we lose doctors to the workforce as a result of caring responsibilities. It's stressful enough being a doctor anyway, but if you add in a caring responsibility, it's really hard. And a lot of people just can't take the stress and are lost to the service. As well as that, there's a personal cost to doctors who stay. There's a gender difference in childcare. Society still expects women to be the main carers of children. This is improving. My husband did a lot more than my father. My son, I think, will do more than my husband. So it is improving, but women still do more. And the latest ONS data that actually looked at that found that women do twice as much cooking, childcare, and housework as men. So there's a difference there. And women are more likely to take on caring roles than men. And if you look at women in the age group 50 to 64, 1 in 4 of them have responsibilities for older parents or disabled parents. There's an unequal impact on careers. Women doctors are more likely to take time out. They're more likely to have periods of working or training less than full time so that they can care. And this has a disproportionate impact on their pay. Even if you look at the hours worked and the periods of leave, if you look at the time that they actually work, they get paid less for it. This is the gender pay gap in medicine in England, so adjusted for the working hours. So women doctors in hospital earn 18.9% less than men. Women GPs earn 15.3% less than men. And women clinical academics earn 11.9% less than men. So really significant gap there. Just to mention international medical graduates, this is people who were born in different countries that have come to the UK to work. They have particular problems. They're less likely to have local family networks, and the visas make it very difficult for family members to come to the UK to help, and really hard for them to care for aging parents who might be half a world away. And COVID-19 has made this worse. It's been really awful for people who have parents far away who they haven't been able to visit. So it's a whole nother layer of stress and difficulty for people. Just to mention a couple of wellbeing initiatives, there have been quite a few recently, but here are 2 major ones, both in 2019, one from Health Education England, the Staff and Learners Mental Wellbeing Commission, and one for the GMC, that they called their report Caring for Doctors, Caring for Patients. I sat on the commission. We looked at the wellbeing of learners and staff. We looked at what we were doing at the moment, where things were good and where they weren't so good, and where we could try and improve them. And as part of the commission, we spoke to quite a lot of people. We heard evidence from people in various situations, and we heard about the pressures arising from caring responsibilities outside of work. And a key theme came out in the report about looking after loved ones. We don't work in isolation in the world. We need to think about how our well-being at work is affected by our family and how our work affects them. The Commission made 33 recommendations. Some of them have been implemented, some of them are in the process of being implemented, and many of these will improve the support that we give to doctors who are also carers. The GMC review was looking at the factors that impact on the mental health and well-being of medical students and doctors. And I sat in some of the early workshops and heard some of the early things that came up. And again, doctors who wish to work flexibly often treated as an inconvenience. So that was true in the 1990s. You'd hope it had changed, but it's still there. A conflict between work and home life is a widespread problem which impacts on well-being. Those experiencing such conflict are up to 30 times more likely to suffer from depression or anxiety. Christina had some figures about that as well. And people who experience depression or anxiety are more likely to be exhausted, less likely to be satisfied with their job, and more likely to leave and be lost to the workforce. And we really cannot afford to be losing people to the workforce. So the GMC review again had a number of recommendations, but one around training, learning and development, and making sure that the systems promote fair outcomes and are flexible. That word is so important, flexible, so that doctors and medical students can develop through their careers and can manage their life circumstances. Sources of support. Most employers will provide some sort of support if you're a carer. There's the postgraduate medical education bodies. We have the college support service, and there are lots of other carer support services out there. For example, when my father had dementia, the Alzheimer's Society was a helpful resource for me. The support service, is information about it on our website. There's the link. It's a telephone service. It's run by volunteer members, volunteer psychiatrists. They don't offer counselling or treatment, but they might point you in the direction of services that do. I've not used it myself, but I know quite a few people who have used it and have been pleased with it. So how can we improve things for psychiatrists who are carers? What might come out of today? Well, medical managers, I hope there might be some medical managers watching, or maybe some people who are going to be medical managers. Recognise caring responsibilities, look for hidden carers, don't forget about men, practical support and personalised support and flexibility. And remote working is an opportunity here. I'm not a big fan of remote working, of actually seeing patients over video calls, but it is something, if you're caring for somebody, it can make life easier. So it's an opportunity to keep people in the workforce that we might not otherwise have managed to. And I've seen 1 or 2 jobs advertised where remote working is the whole job. Actions for education bodies, that includes HEE and its equivalents in Scotland, Wales and Northern Ireland, is to think about what we've talked about today. I will take some of this back to HEE, and I'm also going to ask Sabode Davey, our Dean, to help with this, because quite a lot came up in Raka's talk that I think we could help to change. And for all of us, look out for your colleagues, be aware that they may have caring responsibilities. Informal support, even me, I didn't have a huge caring responsibility, but there were times when I really struggled. Just a coffee and a chat is really helpful, and practical support. Sometimes my colleagues would, I don't know, take an on-call off me or do something helpful. It makes a huge difference. So all of us can think about our colleagues and what we can do to support them. So thank you for your attention. There's my email address if you want to contact me. There I am on Twitter, so I can often be found there. So thank you. And we've got a bit of time left for some questions. I'll stop sharing my screen. So we've got 2 questions that I can see. The first one's for Christina. Mm-hmm. Great to finally hear you speak. Please, what's your take on caring roles from ethnic minority stance, e.g. Latinx, African, American, Indigenous American? Are there any differences compared to white carers?
Great, and thank you for this question, Akeem. I wish I was seeing you as well. So to my knowledge, there aren't data specific to racial, ethnic, minority informal caregivers who are physicians. That said, in the U.S., the studies that have been done looking at informal caregivers in general, right? As I said, there's more likely to be women, and they are more likely to be women of color. So that's one of the differences. As we know, women of color experience a lot of discrimination than other women or other people of color that are men. There are challenges, therefore, in getting what they need, how they're experienced when they ask for these things. As Dr. Byrne was outlining, a lot of these because policies aren't in place, a lot of these changes are made on a one-by-one basis. And so it relies on an individual supervisor, experiencing that person who's making a request in a certain way. And so that can be a challenge. I think there's also cultural expectations. You can't tell from my name, I'm Latina. My mother's family, I grew up taking care of my grandmother when she had leukemia. That was just expected that we would all, be helping, and that I would get, I would be doing things like that. And something you get from that is you get the family support. Thankfully, my family is financially stable, but I think some of this comes back to wealth, right? And so a lot of people who are coming from racial or ethnic minorities don't have as much financial resources as well. So that ends up being an added stress. And so then if you're a physician, you obviously have more means, but you don't have the added backup. So for example, I'm the primary breadwinner in my family, and so my family relies on my my salary. So those are just some of my thoughts, but it's an excellent question and deserves a lot more attention.
Thank you. There's another question here. Women may be more likely to be carers, and the gender pay gap is relevant, but gender may not be relevant at all. I train less than full-time due to caring responsibilities for parent and sibling, but would have done the same as if I was male. Why is this college holding this event within MHSIG, and might carers who aren't women be excluded? Many support groups mentioned today are women carer specific. Are changes needed? Raka, do you want to say something about that?
Yes, thank you for that comment. It is a very relevant comment, and we absolutely recognize that. And something I always say, because, despite all that being true, it is also true that there is a huge representation among women who are facing all this. And therefore, something we always say is that, our initiatives are not only for doctors, not only for women, but it's a start. So we absolutely recognize everything you said, and we believe in that and stand for that. It's just that it's always easier to start small and then go from there. Thank you.
And I think, attitudes are changing, and I think there will be more male carers, and we will need to think about them more. I mean, this webinar wouldn't exclude anyone. It was advertised to every single member, and anybody could join. But yeah, it's good to hold it in mind, isn't it?
Yeah, and I think I'll just add, at least here in the United States, I think that part of the cultural change, right? Even in raising children, men are much more involved in childcare now, and male residents and male faculty want their family leave too, right? And so I definitely I know many incredible men who've been caregivers, including my husband.
My husband had half an hour off for our second child. He finished at 4:30 for our second child once. That was it. But I'm sure my son, when he has children, I hope, will take longer. Yeah. All right. There's another question here around exams. I'm thinking about the inflexibility around examinations. Is this part of the conversation? Yeah, exams are inflexible. What's often inflexible is the time periods between them. That's actually the GMC that sets that, not the college, because I know when I was dean, I tried to change that and discovered I couldn't. It was the GMC that sets, if you, our exam, Christina, is divided into 3 parts, but you have to move on within a set amount of time, or you have to go back to the beginning again. So yeah, that is a problem. I mean, there are reasons for that, but it might be worth asking the GMC to look again. I'll talk to Subodh about that. And another question: do we have any recommendations for when trainees need time off for caring? I'd hope for an UPI, but it requires 4 to 6 months notice, not suitable for carer needs. Tried to find out what would be needed if I needed longer time off, was advised to raise it when I needed it. Raka, you talked about you'd had breaks. How did you manage to negotiate those?
I didn't, which is why we're having this webinar.
Right.
It's been extremely difficult, exactly for the reasons that this person kindly has highlighted, that there is, and that's why in my presentation I said that both training and work expect you to have a crisis-free trajectory. So there is nothing in space and place, and it needs some creative thinking. One of the ways in which I was able to carry on was because I also had and I have an honorary contract with the research institute, and so that allows me to jump between the two. However, it is something that absolutely needs active thought, because these are things that can't be predicted or planned ahead. But if we did think of training and job plans as a creative sharing between a sustainable and a non-sustainable options together, then you might jump between the two when required. Thank you for raising that question.
And that's a lovely note to finish on. And Raka, I think you and I should have a conversation with the Dean about all the things that have come up today and see what the college can do to help. So thank you, everybody, for joining. Thank you for the other two speakers. Thank you to Raka for organising it. And thanks to Charlotte and Emma for your support. And you'll get your certificates emailed to you. Thank you.
Thank
Bye.
you. Thank
Bye.
you.